Hi, this is Michael Daly. I'm the medical director for REMO and the chair of the Collaborative Protocol Committee. I welcome you to this comparison of the 2015 and the 2017 collaborative protocols. This is a brief overview designed to familiarize you with a few of the new protocols and some of the changes. This does not substitute for you reviewing these protocols on your own. Development of the collaborative protocols has been an incredibly exciting opportunity. This has combined EMS providers from basic life support through advanced, as well as physicians, nurses, pharmacists, other medical professionals, and our support staff at the program agencies, as well as the Bureau of EMS and Trauma. This has been an incredible opportunity for us all to work together. The fact that this has been a collaboration means that some things have been taken from protocols right the way across the state, and best practices have been merged to assure the best outcomes for our patients. We know that these protocols will continue to evolve as medicine changes and our care provided in the field is reviewed. One thing that's really important for every EMS provider to recognize is that moving into a new set of protocols will take some patience, but we all need to work together to improve the care of our patients across New York, and the collaborative protocol process has been one of the ways that we are clearly advancing care for all New Yorkers. Before anybody gets upset, the protocols have grown from 94 pages to 125. But much of this is because some of the protocols scroll to 2 pages, where previously they had only been 1. There are a few new skills and a few brand new protocols, but in general, this covers a similar amount of information. We have reordered and regrouped the protocols. Things like pediatric arrest are now in a single section for cardiac arrest, but will remain independent when viewed through the app. Most of the protocols have been grouped under general because it's difficult to tell exactly how to officially categorize some of these protocols. This is something that will be a work in progress, and there was a lot of discussion on, and we'll see what ends up serving our EMS community the best. You'll notice that EMT basic skills and scope continues to expand, and along with that, you'll notice that there is more focus on EMT skills throughout the protocols. Look for this to continue to grow too. Among the skills that are added in this set of protocols, transmission of 12 lead for acute coronary syndrome if the agency is equipped, and intramuscular injection for 1-to-1 epi through the check and inject program if an agency is involved in that. You'll also notice some protocols that have been combined, like PEA and Asystole, which frankly the care is essentially the same. We've added and expanded criteria for field termination and redefined obvious death. These 2 protocols involve options without medical control. We recognize that this isn't something that's going to be easy to do, to decide to terminate a cardiac arrest, particularly if somebody's a basic life support provider and has never done this before. But what we took into consideration was the likelihood that there was the potential we would end up injuring personnel through transporting with CPR in progress, as well as the fact that, frankly, there are cardiac arrests that we will not get back and will be a terminal event, and we needed to recognize the difference. We separated diabetic emergencies into hyperglycemia and hypoglycemia because they're 2 different processes and need to be taken care of differently. We added a protocol specifically for hyperkalemia, or high potassium levels, because this is such a deadly complication of renal disease, and we wanted to make sure people could focus on it independently. We also separated the agitated patient from excited delirium, because excited delirium needs additional standing orders to make sure that providers can take care of themselves and their other brothers and sisters in public safety should that presentation occur. And we wanted to make sure people were thinking differently about the agitated patient in a nursing home, or the true excited delirium patient who's fighting with law enforcement in the street. General overview of new protocols of interest include advanced directives with some clarification of how to use them. There's also additional training available for this section. Amputation, heat and cold emergencies, musculoskeletal trauma. Patella dislocation is a brand new protocol for EMS altogether, as there are very few places where this is included in protocols across the country, but it's something that is frankly quite safe. That training material is also available through another resource. Post-intubation management with fentanyl and Versed to make sure the patient is comfortable. Prescribed medication assistance, clarifying what can be assisted, both for basic life support providers as well as for advanced life support providers, so we can provide optimal care for our patients at all times. And use of an automatic transport ventilator. While we developed the protocols, we also removed 3 protocols. Adult upper airway obstruction, which frankly probably wasn't necessary. Removed pediatric trauma triage because it's included in the CDC trauma triage process. And eclampsia, which is defined through seizures. We also removed procedures. And the reason we removed the procedures is because these need to be defined regionally, because care really is local for some of these, where it's not the medical care, but it's the resources available, including medication and medical control, because medical control will be defined differently in each region. Fireground rehab, which also will be defined on a regional basis. Aeromedical utilization, which will be defined based on regional resources and regional expectations. And specialty care transport, which will be very different depending on which region is involved. I'm going to start actually with one of my favorite protocols, which is patella dislocation. I'm really proud that the collaborative protocols has added patella dislocation because it's an opportunity for us just to purely help our patient. Patella dislocation is a skill that has separate training material that you need to go through. There is a training video on the REMO website and should be available through each regional website. And there's a data collection tool that should be on the websites as well, which should be used after each implementation of this protocol. We need to know whether or not the training material is giving you the skills that you need in order to perform this key skill in the field. We believe that it is, but please help us by completing the data collection instrument. General protocol prescribed medication assistance should actually be called the do the right thing within your scope of practice protocol. What we ask is that EMS providers provide the care that they can within their scope of practice to assist patients who are in need. This includes assisting with sublingual nitroglycerin, as it always has in the past, assisting with inhalers or auto-injectors. It also includes assisting with rectal administration of medications like Diastat for children or adults with special need. That frankly is a skill that we are not going to ever ask EMS providers to do on their own. But if a family member or a caregiver needs assistance with administering these important drugs, an EMS provider would be absolutely perfect to assist. For advanced providers, including advanced EMTs, critical care, or paramedic, we ask you to provide vascular access as necessary and then reconnect any pre-existing drips that may be needed if the patient loses long-acting or long-lasting vascular access, or assisting with intramuscular injections as necessary. Determination of obvious death is actually not something that's changed at all. The most important thing to remember is that if somebody has a MOLST or an EMOLST or an out-of-hospital DNR that indicates no resuscitative efforts, please make sure to follow that. If you have any questions at any time, obviously call medical control. The medical consultation physician would be more than happy to discuss what the most appropriate course of action would be. So patients who've had trauma and now have no cardiac activity can be considered obvious death. What's notable here is that if somebody has a mechanism that's not consistent with causing a traumatic death, they should be considered a medical cardiac arrest and not a trauma cardiac arrest. So if somebody bumps another car at low speed, that may very well have been a medical cardiac arrest that caused the initial insult. If patients have been submerged in water for greater than an hour, regardless of what that water temperature is, they will not survive. Therefore, this is one consideration for obvious death. And throughout this, something that's important in the key points and considerations is that if basic life support can review these situations and say, this is someone who's been submerged in water for 2 hours, for example, you don't need advanced life support to determine that that patient is indeed dead. Termination of cardiac arrest is something that now has a series of standing orders that can be met by critical care or paramedic providers, or in cases of radio failure based on regional protocol, EMTs or advanced providers. And this would include patients over the age of 18, unwitnessed arrests, no bystander CPR, no shock ever delivered, no return of spontaneous circulation, and at least 20 minutes of resuscitation. What's important to recognize is this is evidence-based directly out of the Research Outcomes Consortium and is very well validated. The reason that we selected age 18 or older is because we didn't want to provide additional stressors on the EMS provider for determining that an infant or child was dead, and that it made more sense for us to protect those EMS providers from making that decision without a physician. You'll notice that we've combined the Asystole and the PEA algorithms. The reason that these two have been combined is to make sure that we recognize that it's just essentially the same care. For ventricular fibrillation or pulseless V-tach, you'll notice that paramedics can treat suspected hyperkalemia or acidosis with sodium bicarbonate and calcium chloride. They can also treat hypomagnesemia or torsades with magnesium. For return of spontaneous circulation, which obviously is our #1 goal in cardiac arrest management, one of the things that we ask that's most important is going to be a 12-lead electrocardiogram as soon as possible after that patient is stabilized. You'll notice that now we do not any longer ask to give antiarrhythmics right away after return of spontaneous circulation, because our cardiologists were actually finding that this was actually less than effective. Medical control considerations still do include either amiodarone or lidocaine as appropriate. We also ask that we maintain a mean arterial pressure of at least 65 millimeters of mercury or a systolic pressure of over 100, giving 2 liters of saline if there's no pulmonary edema, and starting a norepinephrine infusion as appropriate. Airway management and oxygen delivery is essentially unchanged, except for adding in the ability for an EMT to use CPAP or continuous positive airway pressure masks if needed, equipped, and trained. This is not a requirement for any agency to perform. You'll also notice that operating an automatic transport ventilator with a mask is completely within the scope of practice of an EMT. Advanced providers can use nasal cannula up to 15 liters per minute during intubation attempts and if assisting with a rapid sequence intubation. They can also perform oral endotracheal intubation in unresponsive adults and use alternative airways like King, iGel, or LMA airways. Critical care techs can use age-appropriate pediatric laryngoscopes and McGills in cases of obstructed airway, and paramedics can perform nasotracheal intubation in adults if they've been trained and if their region approves of this skill. Not each region will. Pediatric intubation remains in these protocols, but specifically only if unable to effectively ventilate with a BVM and basic airway adjuncts, because of clear recognition of the difficulty for maintaining this skill set. For confirmed ST elevation MI cases, recognize that basic life support providers may acquire and transmit 12-lead electrocardiograms if their agency is equipped and if they are regionally approved to do so. This is certainly a skill that will be very helpful in some communities, but has a very significant price tag associated with it for purchases of the equipment. We strongly recommend transport to facilities capable of primary angioplasty if the time is less than 90 minutes to get there directly. However, recognize that this is something that may provide regional stressors based on staffing patterns within the region. This ultimately should be determined by medical control, agency policy, and regional policy. You'll notice the EMT section for stroke is longer than most. And that's because what we did is incorporate the most important pieces of the BLS stroke protocol into our protocol for the collaborative. One of the things we talk about here is making sure to determine the exact time the patient was last in their normal state of health, or last known normal time, because EMS has more of an opportunity to do this than we initially do in the emergency departments. And this ultimately provides the most important window for us to know that we are going to be able to give clot-busting medications or thrombolytics safely. We ask that if the symptom onset to arrival in the emergency department time will be less than 5 hours, for these patients to be transported directly to a Department of Health designated stroke center. And if that's not going to be possible, or the patient requests another facility, consult medical control to discuss an appropriate destination. For critical care techs and paramedics, you'll notice there are no standing orders for hypertension, and that we request that you actually maintain a systolic pressure of at least 120 or a mean arterial pressure of greater than 90, because that will allow us the opportunity to maintain appropriate cerebral perfusion pressure. If a patient is hypertensive, it may very well be because that's necessary for appropriate cerebral perfusion pressure. And many times we will not treat that aggressively in the field. Cardiogenic pulmonary edema, or acute pulmonary edema, is another protocol with important changes. First, for EMTs, it allows the opportunity for the use of CPAP as equipped and if trained. Also, you'll notice a change in the way we're providing nitroglycerin, with really aggressive nitroglycerin regimens. And that what we ask is 1 dose or tablet every 5 minutes if the patient's blood pressure is between 120 and 160. 2 doses or tablets every 5 minutes if the patient's blood pressure is 160 to 200, and 3 doses every 5 minutes if the patient's systolic is higher. The reason that we ask to do this is that aggressive use of nitrates is one of the most important things that we can do to improve patients' breathing when they're suffering from pulmonary edema, and this can be life-saving. We do recognize that it's a nuisance to take off the CPAP mask in order to give the nitro and then to put it back on, but that annoyance is far outweighed by the amount of benefit that we get from high-dose nitroglycerin therapy for these patients. You can also use albuterol and Atrovent as appropriate for these patients, but only if there are wheezes present. Because remember, albuterol is a beta agonist, and a beta agonist is going to put more work on the heart. So only if there are cardiac wheezes should you use albuterol and Atrovent. The excited delirium protocol actually starts with a review of exactly what defines excited delirium. This is not just somebody who's cranky and not doing what you ask. This is somebody who's actually truly delirious with psychomotor agitation and altered mental status, who's not responding to appropriate redirection by EMS or law enforcement personnel. This also includes lack of tiring and an unnatural pain tolerance, diaphoresis, and the feeling of hyperthermia if you touch the patient. This also has unusual strength, and it's really important to recognize that these patients are being destructive, erratic, and bizarre. The potential here is for serious harm to the public, potential death for the person suffering through this condition, and injury to members of public safety. This is something that EMS needs to act on, and act on quickly. You'll see that therapy is defined in terms of which medications your agency is carrying. For patients with access to ketamine, recommendation for treatment is an immediate 250 milligrams of intramuscular ketamine. If, on the other hand, you have midazolam but not ketamine, it's 10 milligrams of intramuscular midazolam. Goal here is to sedate these patients and sedate them quickly. If after 5 minutes, either your initial dose of midazolam or your initial dose of ketamine has been ineffective and the patient is still uncontrolled, you may give another dose of ketamine. You may not repeat the Versed without talking to a physician. If the patient remains out of control at 5 minutes and the patient has already gotten 10 milligrams of midazolam, the physician that you talk to may suggest that you go with haloperidol or with more midazolam. It's important to recognize that we do have intravenous medications that are medical control considerations if the patient is already restrained enough to get an intravenous line. But the standing order medications are only intramuscular because our assumption is that if you can get an IV, these patients are probably not in excited delirium. Recognize that ketamine may only be administered by paramedics because of Bureau of EMS and Bureau of Narcotics Enforcement policy statements. Also recognize that if an agitated patient goes into cardiac arrest, consider the possibility of acidosis. The reason we say that is these patients are probably profoundly acidotic and will benefit from high-dose sodium bicarb as their first-line drug. The key points and considerations of this protocol are extremely important for you to focus on. If you're a critical care tech, Bureau of Narcotics Enforcement and Bureau of EMS policy are clear. You may not administer ketamine. Make sure that your agency's policies surrounding working with law enforcement in transporting these patients are things that you focus on for your safety and the safety of the patients involved. Use a team approach at all times to try to mitigate any potential hazards from the patient and to make sure to keep everybody around as safe as possible. Recognize that ketamine and haloperidol may not be available in all regions and with all agencies. So make sure to think through how you're going to treat these patients. Do review these on an agency level every time a situation like this occurs. And recognize that this is a very, very infrequent occurrence in the elderly. As you review the acute asthma protocol, see that there's actually some changes here because for EMTs, we still have the medical control consideration for the use of epinephrine, which is a very reasonable thing for you to do because you should have access to intramuscular epinephrine. For the profoundly ill asthmatic, this can be life-saving. For our advanced providers, consider the idea of using the epinephrine if there's severe distress. And for all of us, we need to recognize that now epinephrine's nomenclature is changing, and that we're no longer going to call it 1 to 1,000 epinephrine, but we're going to consider it 1 milligram in 1 ml as the concentration. That's much clearer to understand. This protocol is the first time you're also going to see a new drug, which is dexamethasone or Decadron. Decadron, for which there's separate education, is a long-acting steroid that can be given intramuscularly, intravenously, or orally, and is an extremely strong steroid that will last for several days. This is one of the evidence-based changes in the protocols that will be evident in your drug box, because dexamethasone will improve outcomes in our asthmatics. For our paramedic providers taking care of pediatric asthmatics, you'll see that there is a dexamethasone option for you. This is also a medical control option for our critical care techs. And this is again to give dexamethasone at the standard dose of 10 milligrams PO, IM, or IV. This is an option for our patients that are over 2 years old. While COPD exacerbation is frequently lumped in with asthma, it's actually a different process. So it now has its own protocol instead of being lumped together. One thing that's important to consider here is that magnesium is a medical control option, not a standing order for the COPD exacerbation, because it's extremely less likely to be useful, and it is more likely to cause complications. We'll see that we have separated diabetes into hyper and hypoglycemia. We did this because hyperglycemia and hypoglycemia are two profoundly different things. And you'll notice that previously, for an EMT, there was a requirement that if a diabetic was abnormal or acting abnormally, they'd just give sugar. Now we ask for blood glucose to be checked and not to give glucose if the patient has confirmed to be hyperglycemic. We're collecting more appropriate, objective data and using that data to treat our patients. This is just plain good medicine. For all of our advanced providers, we're asking to give a normal saline bolus and then repeat it if the patient is hyperglycemic. This is all taking care of patients the way they would be initially cared for in the emergency department, and it's just plain good medicine. For our hypoglycemic patients, we ask, as always, that if possible, allow a patient to self-administer glucose or another carbohydrate source. If they can swallow on command and they have a normal mental status, that's the best way to treat the patient. If, on the other hand, the patient can't swallow on command, then the right thing to do is to give them an infusion of D10, dextrose 10%. And you'll notice that the protocol says up to 25 grams or 250 mLs. If the patient's mental status improves to the level where they will be able to take oral repletion from there, stop the infusion. You don't have to infuse the full 250 mLs of dextrose. The patient's always better off to take carbohydrates by mouth if possible. You'll notice that hyperkalemia has some specific criteria, which is really looking at the potentially fatal cardiac rhythm disturbances that can happen with known hyperkalemia. This protocol itself is for patients with renal failure who should be receiving dialysis but may have skipped it, for patients with known elevated lab values, for patients who may have renal failure but aren't getting dialysis yet, and for patients with crush as well. There are no standing orders for hyperkalemia except for paramedics when there's cardiac arrest or rhythm change during a rapid sequence intubation following the use of succinylcholine. All medications for hyperkalemia should be given in consideration with the physician. You'll notice the drugs that we use are either sodium bicarb, which is 50 milliequivalents IV, or calcium chloride. But the calcium is only given if there's QTc prolongation or suspected QRS widening. One protocol people have been asking for to have a change was nausea and vomiting, because Zofran does not work particularly well for motion sickness. Diphenhydramine or Benadryl actually works reasonably well for motion sickness and has been added as an option for paramedics and critical care techs. Procedural sedation is very specific in that we really use either midazolam or fentanyl, but not both. Please call and talk to a physician about how you actually want to use these medications. Other medications that could be used include ketamine if available and etomidate, and these are also physician options. When you use midazolam and fentanyl together, you create the possibility of a synergistic effect and respiratory depression, and the risk and benefit ratio should be considered in conversation with the physician. Every paramedic should consider which drug they'd want to use at which time, because some people will do better with a little bit of sedation from the midazolam, and some people may need more pain management first with the fentanyl. You'll notice that post-intubation management in specific, we ask for management using fentanyl and midazolam alternated, with the fentanyl being given intravenously about every 5 minutes and the midazolam used every 10 minutes. Ketamine can also be substituted as needed, and in particular, we ask that ongoing paralysis be only done if necessary for patient or crew safety. There is one rather large change in our ventricular assist device protocol, which is now we ask that CPR be performed if there's no evidence of the pump functioning and the patient is unresponsive. We realize that there is a concern, and it's real, that the ventricular assist device will actually disengage from the heart and cause profound intrathoracic bleeding if CPR is performed. However, if these patients have no evidence of pump functioning and they are unresponsive, they are probably not perfusing their brain, and CPR is the only thing that might. These are patients that are profoundly ill, being bridged in many cases to a cardiac transplant, and the chance of their death is very real. These patients should always go to the most appropriate receiving facility, and that receiving facility should be notified as soon as possible. At any time, if the family has advice to give you or a phone number to give you of someone to contact for additional advice, please take it and use that as part of your care plan. This has been a really brief review of the protocols, in particular for people who are already using the collaborative protocols across the eastern section of New York State. Make sure you also download the app onto your phone, print up the protocols if you prefer, and review these on your own. You'll pick up more subtle changes, but most of the other changes are relatively small. Make sure to review any other educational materials that are out there. Your program agency and your agencies will have those available to you and may actually make time for you to do these reviews if appropriate. The patella reduction video is something that I recommend that everybody see on their own, because this is something where you can drastically improve patient care. And it's something that you can start to implement as soon as your region says that it's appropriate. None of these protocols will ever be a substitute for good clinical judgment. The providers that we have across New York State do a great job every day. And the reason is because you care for the patient that's in front of you as effectively as you absolutely can. Your EMS physicians are here to help you. Call us and call medical control should you have any questions or need any assistance. And from the Collaborative Protocol Committee, I invite you to make sure to share any thoughts, ideas, comments, or criticisms of these protocols with us. We want to continue to build these protocols as quality, evidence-based EMS medical document that will help you provide optimal care for your patients. We want to know as much as we can from you. So share these with us through your agency or through your program agency. We've come to the end of my brief overview. I really hope it was helpful. Thank you for taking the time to join me.